Hi, my name is Jo Abbott. Thank you for joining me in this short presentation using a hands-on approach in musculoskeletal healthcare. I'm a biomechanist and a researcher currently living in the UK. My PhD supervisors were Dr. Penny Hudson, Professor Beverly Hale, and Professor Jason Lake from the University of Chichester. My PhD was part-time, self-funded, and had no sponsors. This PhD was conducted over 7 years, was multicultural and multidisciplined, with a special interest in how manual therapy supports the general population avoid lower back pain and osteoarthritis of the hip and knee. The journey included a critical literature review of musculoskeletal ill health, a literature review on the history of using the hands to heal others, a methodological literature review of manual musculoskeletal testing, a systematic review on intertester and intratester reliability studies, and 9 international experimental studies with 436 volunteers, of which 185 were practitioners of manual therapy and 251 were the general population. As previously mentioned, this PhD initially explored all those in medicine that use a form of manually assessing a person's musculoskeletal system to inform that person's care. These professionals include, but are not limited to, practitioners of manual therapy. It has always been thought to manually assess another person's musculoskeletal system, 2 methods are used: observation-based methods and palpatory-based methods. Therefore, in musculoskeletal healthcare, our choice of measurement instrument when manually assessing a person in clinical practice or when placing equipment on a person for research purposes, we all use both observation-based and palpatory-based methods as our measurement instrument of choice because there is no other alternative. It is the outcome of that assessment or that research that proceeds to inform a person's care or improved practice within specific populations. So to summarize, observation and palpation are used as the measurement instruments that inform patient care. For a measurement instrument to be used to inform patient care, it must have evidence of its validity and reliability. Key to this presentation of whether observation or palpation is a valid and reliable measurement instrument is validity evidence must precede reliability evidence. Therefore, when conducting research on measurement instruments, there must be evidence of validity before reliability studies commence. Reliability studies commence only when validity has been achieved. Let's consider the studies that have been conducted on using these methods to perform musculoskeletal assessments that inform patient care. In their entirety, the research community have only conducted inter- and intra-reliability studies on observation and palpation methods used in manual therapy and continue to only conduct reliability studies on these methods without the necessary preceding validity evidence. Without validity, conducting reliability studies is unethical, it's biased, it wastes resources, and misinforms science and practice. Furthermore, albeit the research community render these methods as unreliable, i.e., palpation and observation-based methods, they continue to use these methods as part of their experimental methodology. In fact, of 7,582 studies that were used in my systematic review for this PhD, 99% of them used these methods as part of the inclusion or intervention criteria. For 70 years, inter- and intra-reliability studies have been conducted on observation and palpation being used as a measurement instrument to inform patient care. Of the 7,582 published research papers that made it into my systematic review, none of these reliability studies had conducted validity on the methods used. To study reliability of a measurement instrument without first knowing it has validity is bias, because without validity, there will always be no reliability. To use a measurement instrument without the evidence of its validity is termed reverse bias. As already alluded to, observation and palpation are used by multiple disciplines in musculoskeletal healthcare. However, 98% of the 7,582 published reliability studies only explored the reliability of practitioners of manual therapy when using these methods. This indicates the reliability studies have a sampling bias. Worse still, over the next 10 years, if the point of validity needing to precede reliability doesn't change, a further 250 reliability studies will be published, adding more misinformation to the already contentious hands-on, hands-off debate. The greatest threat to musculoskeletal healthcare is the replication crisis. This is a term used to describe research that cannot be reproduced. And guess what? This is a problem we have seen and reported in manual musculoskeletal testing reliability studies for decades. So to conclude, without validity of a measurement instrument, the findings from reliability studies may simply be an accurate measure of the prevailing biases of the researchers. In this presentation, I will introduce how I have validity tested both observation and palpation-based methods to be used in musculoskeletal healthcare, demonstrating if the criteria is considered, learnt, applied, and practiced, it can in fact meet the gold standard measurement required for a measurement instrument to be used in healthcare. This is the first time in history these manual methods have been exposed to validity testing, and it certainly supports a new conversation for the musculoskeletal healthcare industry. Please remember, in this presentation, I am only providing you with the summary information from 7.5 years of research. If you wish to learn more about the specifics of how these conclusions were reached, or you wish to learn more about how a hands-on approach can be a gold standard measurement instrument, please contact me on the details below. Due to the multicultural and multidisciplinary approach I took to this PhD, it is important I clarify some of the terms I shall be using in this presentation. Firstly, testers is a term I use to describe the person doing the manual musculoskeletal assessment, and testee is the person whom the assessment is being conducted on. Secondly, the evidence within this PhD suggests there is much more to a manual musculoskeletal assessment than observation and palpation. To reflect what is truly occurring, the term hands-on data acquisition and analysis best describes the mechanisms and shall be referred to as HODA throughout this presentation. When I applied the evidence I'm about to share with you in this presentation, my HODA met the gold standard level required to be used as a measurement instrument to inform patient care. However, this does not mean your HODA will reach gold standard by the end of this presentation. I am working on those resources right now. You will require much more depth of knowledge and testing to meet that gold standard. However, within my research, there is evidence to suggest if you are an open-minded person with no limiting beliefs about your specific practice and you are able to reflect upon the evidence within this presentation, your HODA performance will improve. This presentation is biased towards practitioners of manual therapy because they were the most relevant musculoskeletal health discipline to answer the original PhD hypothesis. The aims of this presentation are to provide you with conclusive summary evidence on the mechanisms that underpin HODA during a manual musculoskeletal assessment, in the hope that this new evidence and the new knowledge stimulates a new narrative on using a hands-on approach in musculoskeletal healthcare. The first steps to validating a measurement instrument that is to be used in musculoskeletal healthcare to inform patient care is to conduct a developmental study. A developmental study employs a stepwise approach to validity questioning of a measurement instrument. Part 1 concerns itself with the measurement theories, and Part 2 requires a conceptual framework. Part 1, we are exploring the what's. What are we measuring, and with what are we measuring, and if this can be explained and evidenced. Part 2 requires an explanation on how the measurement theories relate to one another. To summarize, HODA is underpinned by 8 measurement theories within a complex system conceptual framework. The rest of this presentation explores these developments further. The first measurement theory is interoception, and is the tester's awareness to have capacity to calibrate their intrinsic and extrinsic errors, providing them with a 0-0 origin to collect data from. An example of this would be if the tester needed to sit on a stool to collect accurate data, and if not sat, the data collected is just noise. There are physiological, biomechanical, and psychological factors suggesting to underpin interoception, all very individual and unique to the tester. But it is important to note, some testers have no awareness nor skill yet to calibrate the noise out of their systems. Measurement theory 2 is when your life experiences are stimulated. Sensory motor memory stimulation is underpinned by the library of experiences you have to date, reflective of both your personal and clinical life experiences. An example would be if a patient comes in with lower back pain. This measurement theory is reflecting on all your lower back pain life experiences. This measurement theory is also influenced by your ideological stance, your mindset, personality, culture, and lots of human nature. Ultimately, measurement theory 2 is the difference between an accurate measure or a measure of your prevailing biases. Measurement theory 3 is being a care ethicist, and it is the foundation of the practitioner's level of care towards patients. There are 3 specific levels of care. The highest level of care increases HODA performance. An example of being a level 1 care ethicist is when a practitioner is aware of their cold hands and warms them up prior to actively touching a patient's body. An example of level 2 is when a practitioner marries their energy and language with the patients. And unfortunately, level 3 is too complex to discuss here. However, if you would like more information, you can contact me on the details below. Measurement theory 4 is sensory cross-model judgments. And this describes the process occurring when you observe a patient prior to actively touching them. Examples of this occurred during the COVID pandemic when a collection of testers reported they had been doing really well with the online observation-based methods in getting their patients well. But it wasn't until the COVID restrictions were lifted that they were then able to touch their patients that they then found they'd missed multiple things. And when observation is combined with hands-on, they were then able to progress their patients so much faster. Measurement theory 5 is about mechanoreceptors. Mechanoreceptor stimulation describes the mechanisms that are activated and modulating, refining the quality of active touch. In the hands, the mechanoreceptors are randomly distributed throughout, emphasizing the need for a whole hand approach needs to be used when optimizing HODA performance. Likewise, various parts of your hands do best at collecting specific details during a manual musculoskeletal assessment, i.e., consider how you would apply a force to a patient, to then exploring their tissue tone. A further example was during a post-experiment interview. Grouped testers discussed the ability of their hands to constantly modulate when searching for information. Measurement theory 6 is intuition, a subconscious process enabling effective decisions to be made when faced with information noise or insufficient information. Albeit scientists use intuition, it's a tough measurement theory to provide the most evidence on, because within science, we are not yet able to measure intuition accurately. Within my studies, a beautiful description of intuition that kept occurring during post-experimental interviews was described as the process of quietening the practitioner's senses, like when trying to hear the violin when the whole orchestra is playing. Measurement theory 7, during active touch, exploratory hand maneuvers is part of the sensory-motor integration. The integration of data collected via active touch is performed in various parts of the brain. For feeling, it's processed in the somatosensory cortex, and for logic, it's processed in the prefrontal cortex. Critical to this point is the study by Nyberg and Russell Smith in 2013. Within this study, the authors note that the somatosensory cortex demonstrates the importance of trusting our sensory perceptions during a manual musculoskeletal assessment, rather than critically analyzing and overusing associative areas in the prefrontal cortex. They stress both educators and students in manual therapy need to be aware that excessive prefrontal cortex critical analysis may interfere with touch perception accuracy. The prefrontal cortex is involved in many high-order cognitive processes, such as decision-making, reasoning, personality expression, and social cognition. The authors conclude that touch perception should be a primary feeling process and not a primary thought process. Now, measurement theory 8 is a prefrontal cortex process, and it's responding to the information that's been gained through measurement theories 1 to 7, of which is a complete somatosensory experience. The current research suggests somatosensory interpretation is in constant motion until a satisfactory outcome has been reached. It is important to note a gold standard HODA outcome is only obtained if all measurement theories are applied at the highest level. For example, if you lack one of these HODA measurement theories, your HODA performance is reduced. Likewise, if you do not meet the highest level within the individual measurement theories, again, your HODA performance is reduced. So only with the research on HODA measurement theories saturated and evidenced, I was then able to proceed with exploring the conceptual model for HODA that best explained how each measurement theory is related to one another. When studying the how to HODA, the complex system framework is the best model fit. This is an example of an existing complex system framework that provides the how to ACL injuries in basketball. Regularities is the game of basketball. The web of determinants may be neuromuscular control at the knee, ankle, foot or hip. There may be another Weber determinant like training load or environmental conditions. The emerging pattern is ACL injuries, and the recursive loop is the repetition of the whole. So let's now apply the factors of HODA within the same complex system framework. Regularities becomes your HODA 8 measurement theories. The web of determinants are the confounding variables to HODA. They are the variables that, if not controlled or accounted for, will reduce HODA performance by rendering the regularities, in this case the 8 measurement theories of HODA, to measurement error. There are many web of determinants, but for this short presentation, we're going to look at tester well-being. If you are in pain, your measurement theories will be compromised. Likewise, fingertip size. This compromises measurement theory number 5, and cognitive biases cause errors in measurement theory 2. So to summarize, the web of determinants inform the regularities, and the regularities inform HODA performance. However, a critical finding during this investigative process was the impact of the recursive loop on HODA performance. The recursive loop was seen to provide the pathway to clinical expertise, and best explained as a tester giving themselves time to reflect on their practice and reflect on their thinking. HODA's complex system framework as a whole is a reflective recursive loop. Within its 30,000-year history, HODA has finally been exposed to and met the standards required for the initial validity criteria within a developmental study for it to be used as a measurement instrument in musculoskeletal healthcare to then inform patient care. Within my Ph.D, HODA performance continued to meet further validity and reliability testing, including face validity, structural validity, construct validity, responsiveness, reliability, concurrent validity, internal consistency, and cross-cultural validity. In summary, because the evidence-based research has failed the evidence-based understanding, it's time to change the paradigm. Reliability studies have been conducted without the necessary preceding validity studies and are designed with sampling bias and only a measure of prevailing biases. Likewise, any musculoskeletal research that uses HODA as part of the methodology is in a replication crisis. Failure is not a bad thing. It's a critical component to human development. However, the stigma of failure is more than 2.5 million years old and is one of the single greatest obstacles to human progress. Failure is not about a lack of skill, knowledge, or understanding. It is about the inevitabilities of failure when dealing with a complex system such as the human body. When the probability of error is high, such as in complex systems, there is more scope for error, and thus the importance of learning from failure becomes more essential and not less. This presentation you have viewed is only 5% of the investigative findings on HODA as a gold standard measurement instrument. To raise a tester's HODA performance to gold standard, the tester needs to be tested and a depth of knowledge gained of this research. I am working on gifting this new knowledge to you all through presenting at conferences, online lectures, and training days. To stay informed of this development, please get in touch. So what's next? I will continue to research HODA and develop tools and protocols for all disciplines using HODA to be a gold standard measurement instrument. And remember, HODA is only a gold standard measurement instrument when we apply all the principles. Thank you for joining me in my online presentation of HODA. Please get in touch if you have any questions.